Hi folks, I want to make just a few comments before I get into chapter 7. I know that I talk too much, so you don't have to tell me that. I have taught so many years in face-to-face classrooms that I know I'm limited, but yet I have a lot of experience in face-to-face. This is different. I also tend to forget that many of you are not looking at these films, and that those of you who are still have to go back and read the text, get into much more detail than I could possibly get to in a lecture like this. So, that being said, today I'm going to lecture on chapter 7, which is bone tissue. Chapter 8, which will follow, is specifically the skeletal system. And then chapter 9 will cover joints. But that's yet to come. So let's talk right now about bone tissue. Remember that we talked in chapter 5 about different kinds of tissue. There, got everything ready now, I think. Chapter 7 starts on page 202. Please print off the study guide on page 226. As you know, I tend to want to read some of this because I can't say it any better than your author does. In 7.1, we'll talk about tissues and organs of the skeletal system. 7.2 is histology of osseous tissue. That means microscopic look at tissue. 7.3 talks about bone development. 7.4 talks about the physiology of osseous tissue, and 7.5 talks about a few bone disorders. 7.1, tissues and organs of the skeletal system. By definition, the skeletal system is composed of bones, cartilage, and ligaments joined tightly to form a strong, flexible framework for the body. Okay? Functions of the skeleton. Your author lists 6 rules. Support, overall support of the body. Protection, movement, maintenance of electrolyte balance, maintenance of acid-base balance, and functions in blood formation. Okay, bone or osseous tissue, as it is pronounced, is a connective tissue in which the matrix is hardened by the deposition of calcium phosphate and other minerals. This hardening process is called mineralization or calcification. Also present in this tissue organ system are blood, bone marrow, cartilage, adipose tissue, nervous tissue, and fibrous connective tissue. I want you to read the next section to see the difference between flat bones and long bones and short bones. Okay? Flat bones make up most of the bones of the cranium or the head. Also, the sternum, the scapula, the ribs, and hip bones are considered flat bones. Long bones are the most important bones that deal with body movement. This is the humerus, ulna, and radius of the arms, and the femur, tibia, and fibula of the legs. Also, the metacarpals, metatarsals, and phalanges of the hands and feet are considered long bones. The wrists and ankles have, in an adult, 30 short bones. These are very, very small. Okay. Now, if you will look at figure 7.1, you will see the anatomy of a long bone. I am not going to just read all these different parts of the long bone. I leave that to you. On the left-hand side is living bone that's filled with bone marrow, shows the blood vessels. On the right is a dried, obviously dead bone that shows some of what is left over. Okay, now I do want you to read down through on the left of page 204, just so you know what some of these parts of the long bone are. Now, 7.2 talks about the histology. It means the microscopic look at osseous tissue. First, let's talk about bone cells. Like any other connective tissue, bone consists of cells, fibers, and ground substance. The four principal types of bone cells are the osteogenic cells. These are stem cells that develop from embryonic mesenchymal cells and then give rise to all the other bone cell types. The osteoblasts are bone-forming cells. I remember osteoblasts build. Okay, that's one way of telling them, from osteoclasts, which is the fourth type, and these are bone cells that are being broken down. Osteocytes, type 3, are former osteoblasts that have become trapped in the bone matrix that they deposited. If you will look at figure 7.3, you can see how osteocytes develop and osteoclasts develop. Osteoblasts build, osteoclasts, with a C, are bone-dissolving cells, and these are always in operation. The matrix of the osseous tissue is, by dry weight, about 1/3 organic and 2/3 inorganic. Most of the inorganic matter is made up of a crystallized calcium phosphate salt called hydroxyapatite and 10% calcium carbonate. So this gives the matrix a very hard texture. If we look on page 207 at compact bone, and at the same time look at figure 7.7, you will see excellent histological pictures and sketches of osseous tissue. You can very easily see that this bone tissue is not strictly hard bone. There are blood vessels, both arteries and venules, that pass through the bone. There are nerves that also supply the bone. So I want you to look at that photo or that figure 7.4. It would be a good one to print off so that you can recognize all of these different parts, again, of bone tissue at the microscopic level. Bone marrow is a very general term for soft tissue that occupies the marrow cavity of long bones, many of the long bones, the spaces amid the trabeculi of spongy bone and the larger central canals of bone. There are both red and yellow types of marrow. The red marrow, if you will look at part C in figure 7.4, gets its redness because of a large number of red blood cells. This red bone marrow is sometimes called hemopoietic. This is tissue that produces blood cells. The yellow bone marrow has a lot of fatty tissue, and it no longer produces blood. Skipping now to part 7.3, bone development. Now, the process whereby bones are formed is called ossification or osteogenesis. There are two main methods, intramembranous and endochondral types of ossification. I want you to read about these two very much more detail and look at both figure 7.7 and 7.8. These are sketches and then a photomicrograph of intramembranous ossification. In the text, it lists the 4 stages of intramembranous ossification. Endochondral ossification is a process by which a bone develops from pre-existing model that's composed of hyaline cartilage. This is a type of ossification that occurs in the fetus and in the early life of a person up through their teenage years. There are good sketches of this in figure 7.9, where you see it starts with an early cartilage in a baby's hand, shows the formation of a primary ossification center, and then step by step until in figure 6 you have an adult bone with a single bone marrow cavity. Now, there are 2 other very important processes that you should know something about, and this is bone growth and remodeling of bone. Obviously, when a fetus is born, it only weighs somewhere in this order of 6 to 8 pounds and is quite small. These bones need to grow both by becoming longer and becoming wider. The bone grows longer from an area called the epiphyseal plate, sometimes called the growth plate of the long bone. Look at figure 7.11 and you will see an x-ray of a child's hand. And in this photo of an x-ray, you will see pointed out several epiphyseal plates. These are where the bone is able to grow longer. When that epiphyseal plate disappears, and that occurs later on somewhere in late teenage years or into the 20s, then you will know that that bone is done growing longer. Now, it also grows wider and thicker. And that occurs, don't have any pictures of that. Looking at figure 7.12 is another photomicrograph of this metaphysis, or the growth plate. And very, very interesting thing that takes place in our bodies is called bone remodeling. In addition to the growth of bone, the bones are continuing to be remodeled throughout life as old bone is absorbed and new bone is laid down. There was a scientist called Julius Wolff, with 2 F's, in middle part of the 17th century. And his Wolff's law of bone states that the architecture of a bone is determined by the mechanical stresses placed upon it. And the bone therefore adapts in order to withstand these stresses. This bone remodeling comes about through the action of both osteoblasts and osteoclasts. Okay, now skipping to part 7.4, the physiology of osseous tissue. This is very detailed, and I'm only going to hit just on the highlights of it. Even after a bone is fully formed, it remains a metabolically active organ with many different roles to play. Not only is it involved in its own maintenance, growth, and remodeling, it also exerts a profound influence on the rest of the body by exchanging minerals with tissue fluid. This mineral deposition that we call mineralization is a process in which calcium, phosphate, and other ions are taken from the bloodstream in the plasma and deposited in bone tissue. Again, the osteoblasts begin this process. The bones are also very, very important in what's called calcium homeostasis. Calcium is not found only in bones. As we will see later when we study muscles, calcium ions are an intricate part, an absolutely essential part of muscle contractions. And the bones are very much in control of calcium homeostasis. I want to mention now just one other form of an ion that, or a this is a form, calcitrol, back up, is a form of vitamin D that is produced by the sequential action of the skin, liver, and kidneys. It behaves as a hormone, a blood-borne chemical messenger that goes from one organ to another. It is found also in milk products. It is very important, again, for the proper maintenance of our bone tissue and bone organs. Another hormone is calcitonin. It is secreted by the C cells of the thyroid gland. It helps to lower calcium concentration if it raises too high. There are also parathyroid glands that secrete parathyroid hormones. These glands are very, very small and adhere to the posterior surface of the thyroid glands. They release a hormone called parathyroid hormone when blood calcium is too low. When the concentration is too low in the bloodstream, then some of the bone tissue is broken down, and the calcium concentration is increased in the bloodstream. On pages 218 and 219, you see several figures and sketches that show how calcium balance and calcium homeostasis is accomplished. Table 7.1 is something that you want to also look at just before the test that covers Chapter 7. It shows the different agents, not just hormones, but different agents that affect calcium and bone metabolism. And then in the second part of the table, it shows the effects that these different agents have. Now, bone 7.5 discusses a few bone disorders. First part covers bone fractures and their repair. A bone fracture is a complete, no, I won't say that. I would be wrong. A bone fracture is a break in a bone. It is not necessarily completely through the bone. There is no difference between a fracture and a break of a bone. Different types of fractures. A pathological fracture is a break in a bone that has been weakened by some other disease, such as bone cancer or osteoporosis. Fractures are also classified according to the direction of the fracture line. Figure 7.17 shows X-rays of some representative fracture types. Picture A shows a non-displaced fracture. If you look very closely and the arrow shows it, this bone, which is the distal end of the humerus, is fractured, but none of the pieces are displaced. Picture B shows a badly displaced fracture of both of the distal tibia and fibula in an ankle. Part C is even worse than B. This is a comminuted fracture of an ankle. A comminuted fracture is just another word that means it has broken into several different pieces. Part D shows what is called a green stick fracture. This is something that is unique to children, and the name comes from what you would see if you try to break a green stick of wood. Only part of it breaks. It does not break all the way through the piece. The green stick fracture is an incomplete fracture. Now, I do want you to know the four major parts of the healing process. That is shown in figure 7.18 and is described just above on page 222. First step is the formation of a hematoma, which is a blood clot. and granulation tissue. Step 2 is the formation of a soft callus. Fibroblasts have deposited collagen in this granulation tissue. Part 3 is the conversion of this soft callus to a hard callus. Many osteoblasts come into play here, and there is a bony collar around the fracture site. Finally, number 4 is the bone remodeling. This takes place over 3 to 4 months, where there is complete healing of the fracture, and you are no longer able to see the site of the fracture. Now, just very briefly, there are 2 different types of closing or of treatment of fractures. These are closed reduction and open reduction. A closed reduction occurs when the bone fragments are able to be manipulated into their normal tissue without any surgery. And then when a cast, either fiberglass, which is used now most commonly, or the old plaster of Paris type of cast is formed. Open reduction, which you see in figure 7.19, involves a surgery where the bones have to be visualized and then replaced or repaired with plates, screws, pins in order to correctly align these fragments. Only then can the bone be completely healed as we want it to. Table 7.2, very briefly, talks about some bone disorders. All I want you to do there is to know that you have seen these words, the most common being osteomyelitis. This is an infection or inflammation of osseous tissue. This is very difficult to treat and most commonly requires surgery to debride the site of the infection. Another very common disorder is osteoporosis, and this is a generalized demineralization of bone tissue that is very, very common in women, specifically after menopause, when they lose the effects of estrogen. It does occasionally occur in men, but is much, much more frequently occurs in women. Okay, that is a very quick look at Chapter 7. I need you, of course, to go back and read it. Write down some of the terms so that you can recognize them again. Try to print off some of the more important tables and figures. Then you will be ready for the unit exam when it comes up. Thank you very much.